Well, hello there. Here we go. Let's look at theories and see if I can actually get through this lecture and get it uploaded properly for you. That is my intention. So, looking at this day or this week in psychiatric history, I can let you go ahead and read all about Timothy Leary. Some people may know that name, maybe not, but Timothy Leary, as you can see in the bottom part of that paragraph, was a leader of the psychedelic movement, and he's the one that got everybody on LSD. And he's also one of the founders of the Kaiser Permanente Health Plan in Oakland, California, making way for that, and what they, he was one of the chief architects of that plan. So go figure, LSD and Kaiser, and what do we have with that? All right, moving along to the important stuff, which is the theoretical concepts. Okay, so why we do what we do. Everything we do in nursing is based on evidence-based practice, and that would be research. And in psychiatric nursing, we go all the way back to a founding father known as Freud. That's where we kind of begin all of these methods of contemporary, what we do now, types of therapy. There's my dog in the background. Okay, so we move from evil and sorcerers and supernatural causes for psychiatric illness and treatments. And if you review the history, you know that to be true. And we went to the unconscious mind and what was happening underneath everything that we think about day to day. And that's where Freud came in, to the developmental theories and social learning theories and genetics and so on and so forth. And what did we come up with today? Well, let's see. All right, so these theoretical ideas have really developed over time, and they have transformed over time in terms of what kind of technology and research is available. Today, we have a real eclectic approach. We look at multi-causes for the reasons people come down with psychiatric illnesses. We know this when we look at the transactional model in all the different types of diagnoses out there, and we pull together all kinds of different theories as to why somebody comes up with a psychiatric illness. A lot of it is hedging towards the biology component now, although certainly it is our upbringing, our society, our environment, and just how we develop as people. And if we're looking at brain development, that's still under a lot of research right now. Not a lot is known about that. So we're going to explore really the historical ways we know people to behave and develop their personality through looking at these theorists. And this is really looking at your chapter about that in your textbook and focusing on chapter 3, and that's of the current edition that you're looking at today. Okay, so we look at multiple causes in terms of how mental illness arises, and with those theories and hunches and ideas about causes, therapeutic approaches are developed. And the bottom line is really to get somebody back to a level of homeostasis or adaptation. And because some illnesses, there are no cure. We know that. But we certainly know that there are some people that can adapt and become well enough to function day to day. And we see that also in our physical illnesses as well. So bottom line, decrease the distress, or perhaps regain the ego. And that's what the goal is with therapeutic approaches. And in determining the best therapeutic approach, it depends on the therapist and who they would like to adhere their principles and beliefs to. So they may look at just a Freudian or psychoanalytical approach, or they may look at some other things and look at other theorists. And as we go along in the disorders, we'll be bringing this theory back. So let's get some foundational understanding for that. And we'll start with our friend Freud. So he's the father of modern psychiatry, and he is the father or the developer of psychoanalysis, and that's a huge, huge therapeutic principle that we use in terms of treating individuals with emotional distress. You use it in your everyday life, in fact. Freud believed that human behavior was determined by specific and varied life events, and he went through different phases. He had some assumptions. These theorists all have assumptions in their development of their theory. Human behavior, he thought, was to be determined by libido, that it was, and now we know that that really is something inside the brain that triggers us all. Maybe he wasn't quite sure where that was coming from, but he identified it as libido, also known as psychic energy. And that is not just some people, when you think of libido, it's a sexual drive. It's your drive for your basic needs, your need to find food, to address your need, your hunger pains, your thirst drive, and what have you. It encompasses all of that. He also believed that personality was developed by the age of 5. And we'll come to personality disorders, and we'll talk about personality, and we'll wonder, is that true? Was it by 5? Was it by 2? Or were we born with certain personalities or personality traits, looking at that? So some of the things he brought to us to at least question and go forward in psychiatric understanding. Then we go into thinking about what about his primary concepts of id, ego, and superego. Freud assumed that human behavior personality is determined by the id, the ego, and the superego. So looking at the id, it's present at birth. It is the child in us. In a newer form of psychoanalysis, like it was developed in around the 1960s or 70s, is transactional analysis. So, and those theorists took Freudian beliefs and kind of gave different terms to it, more up-to-date terms. So it is represented as the child in us, the impulsive behavior, the pleasure-oriented, not really thinking about consequences, but just after that basic need and addressing that libido without kind of thinking about any other things along with that. Like, is this really a good idea or not? And then ego, Freud assumed that that was developed in infancy. And if we look at kind of core concepts with patients and how we're trying to deal with them, we're trying to help them establish that ego again, that self-esteem, that belief that I'm okay. And this is known as, in terms of more contemporary terms, the adult in us, who is secure with reality. And again, looking at that, we're okay. There was a term, I'm okay and you're okay. And this is something the ego is trying to master all the time. The ego will postpone pleasure until appropriate times, very reality-based, and manages the id reactions. So it kind of takes care of when the id gets out of control. Then there's the superego. Freud felt that this was developed in early childhood, and it's the parent in us that values legal, ethical, and moral regulations, controls the adult and the child, kind of oversees, kind of helps to regulate any type of competition between the two. It can be overly rigid, just as parents can be, causing some conflict sometimes within us. So these little internal struggles, this is all unconscious struggles that we deal with on a day-to-day to do with that. So those are some concepts that Freud discussed, and your book is excellent at really describing this in a not-so-dry way, giving some good examples. So again, I turn you back to chapter 3 to really get a good understanding for this. All right, so what else did Mr. Daddy-O of psychiatry say? Well, personality development, in terms of that concept, he felt that it was in the unconscious mind with the components of id, ego, and superego. We know that already. Personality is developed over stages, and he felt that it was developed by 5, but we look at stages to go a little bit beyond the age of 5. Freud gave us also the word of fixation, being stuck in a stage of development. And we'll come back to that too. So looking at his phases: oral, development of trust, and that's what we also refer to looking at the babies, the infants who are thumb sucking. They get really good gratification. They are soothed when they're able to have oral gratification, thumb sucking, bottles, and what have you, that oral phase. And we know that the babies really explore with their oral senses. And we see that, that Freud, that's all he had to go on, was really to observe these type of behaviors and then identify that. If somebody was then to have trouble in that stage, at that early stage, they would probably have a long life pattern in Freud's eyes of trusting others. And then we kind of look at that. That could be true if babies are not really cared for and nurtured in a sense of that warmth and being conveyed from the primary caregiver, usually the mother. If that's not transmitted, we have seen that definitely is true, that people grow up to not really trusting others. And that's what Freud was dealing with as well when he was seeing people that had emotional upsets in their lives. The next phase is the anal phase, and this is where Freud identified that we learn to control our impulses. Remember, id is here and flourishing, and the ego was already starting to develop earlier and is now getting control over this. We see that in children. This is when they're learning to toilet train, where they're able to get out of the diapers. Now, if you really look at the ages here, this is somewhat doesn't correlate with our now traditional, or now the ways we now potty train or toilet train our children. We know that it takes a lot longer, but back in the day, and I'm talking even as I was growing up and I was a young child, it was thought that if your child could walk, that's when you started potty training them. And we know now that they really don't have the physical ability to do that. So you can only imagine the struggles that my age group and older have, maybe in terms of learning to control impulses because of this issue of not being able to, that being forced basically into the potty training. I'm not saying that I have problems with that, by the way. Okay. The next phase is the phallic phase. This is where Freud identified socialization skills, where we learn to identify with adults of the same gender. Now, right previous to that, and I'm not going into all of Freud's concepts, but previous to that, little children will identify with the opposite sex quite often, and then they turn to identify with the same sex. But you can see where in the past, where having issues of sexual identity, gender identity was actually a psychiatric illness because of these old Freudian thoughts that, hey, you didn't develop properly then in terms of your sexual identity, so therefore that's why you've turned out to have, homosexual ideals, or maybe even the transgender ideals. And we know now that to not be the case in terms of it being an illness. Then the latent phase was for social skills, were also continued at this, and this is where ego growth really developed and skills to cope with the world happened. And we know this to be of childhood age, school age, and thinking about that, you go back to Freudian times in the Victorian era, the 1800s, 1900s, early 1900s. Children were not going to school all the way through 12th grade. They may have only gone through 3rd grade if they went at all. They went right into work, and they also got married very young, and then that arises to the genital phase, where he said that's pretty much where you ended your behavioral personality development, you were done, and you were now a full-fledged adult where you were able to develop relationships, your creativity, find pleasure in love and work, raise a family, etc., because people were of that age getting married and having a family quite early. Ooh, sorry about that. There's my computer and working with that. All right, let's stop that right now. Okay, so some other things with Freud, and I'm just going to move that a little bit. Okay, this is an issue that mothers like me maybe had some problems with in terms of first learning and reading about Freud, that everything was blamed on the mother. And this was clearly one of Freud's fixations, but his peers, actually found other beliefs for psychological problems. It wasn't always the mother. But then again, when you roll back into that era, who was the primary caregiver? It was the mother, the mothering figure, the person that was attentive to these children. And again, what did that mother have to deal with? But a lot of children usually to raise, and maybe not giving always the best attention to them. Okay, so he was fixated on the unconscious mind. I want you to review that, read in the book. What is the conscious, preconscious, and unconscious mind? Because conscious mind, again, is what we know and understand and have our memories, and they're very clear. Preconscious might be things that we actually tuck away sort of in that in-between state of we're not going to think about it all the time. We actively are putting it away so we don't think about it. And we'll find out that when we don't deal with problems that we tuck away like that, tend to creep up and rear their ugly head, causing us problems later on in life. And you'll see that application as we go through some of the disorders. Looking at the unconscious mind, clearly things that are not of the preconscious, we didn't actively tuck it away, it's not of the conscious mind. And those are things that we harbor and live with from day to day that also can cause problems. So he said that, with all that, we, especially in the unconscious mind, in order to protect that ego so that ego doesn't become deflated, we use these ego defense mechanisms to keep that always in a full state, as full as it can be. Remember, these mechanisms really do help to inflate our ego, and when we're feeling psychologically threatened, we will use those ego defense mechanisms. That's normal. That's to preserve the sense of self. That's what we do. But anything that we do in excess, we know can cause problems, and the use of overly using ego defense mechanisms will also cause that. Just look at denial. We actively use denial to in many different situations, and when we're looking at the person that abuses substances, that's a key ego defense mechanisms that is used, and then that becomes very unhelpful. It's good at preserving for a little while, but becomes unhelpful. And then lastly, looking here with Freud, application to practice, looking at psychoanalysis, the movement of unconscious and preconscious material to the level of consciousness to deal with those conflicts. And that's what Freud wanted to do. He wanted to uncover all that. How did he do that? Hypnosis. And that's still used today, definitely. Talk therapy, just by talking and helping to bring these memories out and about, and to bring them or on the forefront. And we heard from our guest speakers who talked about that, who talked about how some in therapy, some memories came flooding back, or they can cause trouble, but then you can work with them and sort through them. Remember, they never go away when we stuff them down into the unconscious levels there. So talk therapy, dream analysis, you can take it or leave it on that one. I don't think anybody's found any clear explanation for the dreams we have. I'm sure there's something there. Excuse me, I had a hiccup. Okay, free association, that's when a therapist will throw out a word, and what is your response to that? And then looking at those responses and saying, okay, what are we making of this? Where did that come from? And trying to help somebody sort through some issues there. All right, let's move on to Erikson. And he also used psychoanalysis. he liked to emphasize more of the ego, and he looked at people kind of more positively than Freud did. He did not think that everybody has an id out of control, but rather wanted to accentuate the ego, and look at that from that aspect. He saw society as influencing our development more so than just the mom or the primary caregiver, and he recognized that we develop through the whole lifespan. So those are some good concepts there to look at. I think your book takes Freud, I just want to step back into that, looking at the genital phase up to age 20, but Freud actually had more understanding that your development was already met before that age in teenage years, even earlier teenage years. Okay, that's neither here nor there. Don't worry about it. Okay, so for Erikson looked at the 8 stages of people, and he called it the 8 stages of man, but we'll look at the 8 stages of people because that's more contemporary. And each stage he felt we faced with either with conflict or crisis, and we are faced with conflict or crisis, and how do we handle that? We either develop through that stage in a negative way or a positive way. And of course, if you deal with it in a positive way, then you can go on to the next stage and continue hopefully dealing with those in positive ways. Each stage as we go through, though, if there is a negative experience, that's when we're probably going to have some psychological issues that are going to arise. And when you look at your patients, we're asking you to compare. What is the stage that they should be in, but where is the stage that they're kind of acting in? And when we look at those actions, that is sometimes where their psychological issues develop. We can almost pinpoint based on their behaviors. Okay, so again, I refer to your book to look at this for more explanation. And the one thing is that differentiating between Erikson and Freud is that Erikson believed that we could actually go back and fix things, whereas Freud did not think about that. So we know 8 stages of people, but his wife decided that there was probably a 9th stage, and that's because Erik Erikson did live a long life, but she lived longer to the age of 90. And she said, well, wait a minute, I think I'm beyond the ego integrity versus despair. What's the next stage? And the next stage, basically, she said, if you live long enough, you need to stay healthy enough so you can continue to experience and grow in life. But the only way you're going to do that is taking care of your body and being able to function. That we might deteriorate physically, but mentally we can stay intact. And we see that with our older people that we get to have the pleasure of encountering in different situations in healthcare. We learn a lot from them. Okay, again, your book really does a great job. Go ahead and review this PowerPoint because this is what we want you to look at in terms of your patient and where they have been, where they are going to, where they're at currently, and we want you to really analyze that. So before we go on to Maslow, I did want to show you this one little part here in your chapter 3 on Erikson. I went ahead and took generativity versus stagnation. Let me go ahead and move that up and around a little bit. Here we go. Okay, so you can see generativity versus stagnation is playing with it here. There we go. I'm still not getting it into your frame here, but it's generativity versus stagnation or self-absorption. So stagnation is referred to as self-absorption as well. 30 to 65 years old. So Erikson, again, he didn't really put an age on this, but we'll use what your book says here. I don't quite agree with the 30-year-old because I don't know if they can generate too much at that point, but that's just my own opinion. All right, so aside from that, what is the major development task? So look at that. It is to achieve the life goals established for oneself while considering the welfare of future generations. So that's why I think 30-year-olds don't exactly meet that. Some 30-year-olds, or certainly some of you are in your 30s or young 30s and you're able to see this, but I just have a little issue with this. I'm not sure. I think we see this a little bit older. Okay, let's get off of that track in my opinion, because it really doesn't matter. But, so looking at this, you can see again, what is the achievement? The achievement of the task results in a sense of gratification from personal and professional achievements and from meaningful contributions to others. So this is the positive sense. How do we get through that? So people who are experiencing generativity, they are able to feel satisfied with where they're at, and they are interested in leaving a better place for people that are coming up after them. Now, non-achievement results in lack of concern for their welfare of others and total preoccupation with self. We tend to see that a lot with people who are experiencing mental illness. It's not to say that they haven't achieved gratification and generativity in helping others and helping themselves as well. They are there because, in the negative realm, because they're experiencing mental illness. That happens with people that are experiencing physical illness. This is what I want to tell you in terms of what you're going to do with your patients. And I'm going to go back to the PowerPoint and look at that. Excuse me, we're a little askew here. I'll bring us over. Okay. So looking at this application of the 8 stages, you want to identify what you see in terms of your patient's behaviors right now, and then discuss why that is happening. So again, they might be otherwise outside of the mental illness or what they're experiencing at this point, generating just fine and experiencing generativity, but they're in a state of stagnation. So look at that and say, all right, then let's compare and see with these behaviors, are they actually experiencing behaviors that are of a younger age, according to Erikson? And so explain that, what's happening. And this is what I'm saying, is that when you look at those behaviors in a younger stage, that patient who's maybe 35 years old is experiencing, we want to compare and contrast that, and we want to say, well, maybe that's also when their psychiatric illnesses started to develop. In any case, do a full analysis on that and really talk about that in your identification of these stages. Okay, so I went off track a little bit trying to explain that. I hope I didn't confuse you anymore. I probably did, but that was not my intention. Moving to Maslow. Here we go. We know Maslow. We use Maslow in part of our conceptual framework for the nursing program. We like to see that we are rising through the pyramid and gaining towards self-actualization, and that's what we're trying to help our patients do as well, and that's what Maslow wanted. He was a developmental / interpersonal theorist, so he kind of hovered on the line there. He loved to view humans as healthy or potentially healthy, so more positive than Erikson even, and he assumed that we have 5 basic needs. Here again, we want you to take a look at Maslow and identify where your patient is. So let's look at this pyramid here, and we can see that somebody who is self-actualizing, let me see if I can, there we go, got the full pyramid in there. Where's your patient in terms of this? And to look at that, let me see if I can get that. There we go. That's even better. All right. So your patient might be in the physiological state who's needing to be taken care of. We need to offer them food and water and shelter and warmth, and just basically take care of their basic needs. So that's when your patient comes in. But where has your patient been in life? I want you to compare that and contrast where they're at. Some people have actually been self-actualized, and they really are looked upon and revered by others, but when we see them, they're in the most dreadful state, and We don't want to believe that they're always in that need for physiological needs being met, but they actually have been along these other rungs. And again, I'm not going to go over into your book, but it's there and it explains this. So look at your patient, compare where they're at right now, where have they been, because it's always about where that patient has been, where we as nurses want to help them get back to. Okay, so that's very important. Don't look squarely at the patient of where they're at, but where they have been, so you can help them achieve getting back there. Now, are you going to do that in the time you're with the patient over these next 8 weeks? Probably not, but you want to think about that with all your patients. Don't just see the patient for who they are at the time that they're in the hospital. That's not normally how they are, and you know that if you've been a patient, right? We're not always like that when we're really sick. We have other things to do, and we are doing other things. So find out about that person and what they're doing. All right, I didn't mean to do that, but I'm doing things like that. Sorry. Okay, next one. Self-transcendence is a next level of Maslow that is not really widely discussed, but again, because theorists like to, and I'm going back to the pyramid there, who are newer and using Maslow, like to say, well, what about this top, above self-actualization? Is there something more? And current writings are saying, yes, in fact, there is something more. So let me just explain this. And I don't think your book goes into that. Sorry, I'll get back to that. There we go. Self-transcendence is a personal journey of self-discovery. To practice self-transcendence, it takes personal effort and a willingness to change. So it's even a higher level above self-actualization. For the purpose of this class, we will end at self-actualization. Okay? Just letting you know there might be talk around town about self-transcendence, and just thought I would let you know about that. Alrighty, now we're going to get to the next slide. And just so you know that your book does not talk about this, and Maslow is featured actually in chapter 2. Okay, so go back and review chapter 2 for that. I think I had you reading that earlier on, so that's where he falls into place. All right, let's look at what does continue in chapter 3 in terms of our development, and that's the theory of object relations and Mahler. So this is sort of important because a lot of psychiatric problems or mental health problems come from the way we separate, and if we effectively separate or not. And we talk about this, and we know this in children have separation anxiety, and believe me, separation anxiety doesn't just stay in childhood. So studying pediatrics, you've seen that, but we have separation issues all through our lifespan. So let's go back to separating from the primary caregiver, your mother, father, whoever was in your life. And to know that there are some issues with separation that we as parents need to pay attention to. So here's, parents, you get ready to be horrified, because I was when I learned about this. But when we decide to go out for the evening and leave our children behind with a caregiver. Okay, sorry about that. This is going to be a little choppy here because my dog was barking, then all the neighborhood dogs were barking. I had to see what they're barking about. Then they're just barking at each other, and now I totally lost where I was, but I think I can recall. Oh, that's right. I was talking about parents should be getting ready to be horrified. Anyway, so you're going out for the evening, leaving your child behind, and you sneak out before they can start crying and throwing a fit. And we do that, right? I mean, I did that. We all tend to do that. Maybe some of you are sitting here going, I never did that, and good on you, because you didn't mess with your child's head. Then I was dropping my older daughter off to preschool. First day of preschool, first day I was ever teaching at the College of San Mateo. We were both having anxiety issues over that day. I went to bring her to the Child Development Center on campus. Great center, by the way. And getting ready to pull my old routine of when she's not looking, I'm running out the door so she doesn't see me leave. And she caught me and she started screaming. And she was hysterical. And I was halfway out the front doors of that center when they stopped me. That means the teachers of that center. And they said, you know what? You can't do that. I said, do what? I knew what I was doing. And she's at this point at the window, plastered against it, wailing inside the classroom. So what am I to do? They dragged me back in. No, they told me I had to go back in, and they said to me right then and there, you can't do this because you are, you're leaving her with this trauma and her to deal with the trauma, and you're not dealing with it with her. And how, like, basically, how dare you do that to your child? Oh my. So I learned then and there that that was definitely a problem. And, I didn't grow up studying all this. I didn't focus on it. And really, when you're a parent, you tend to do things that are not exactly in the textbook all the time or what the experts have told you to do. You figure out other ways, and boy, did I get a lesson learned that day on that. And this is something that can really, really affect your child. So what I'm trying, look at this, birth to 36 months, birth to 3 years old is where the kids have really a lot of issues. So you have to effectively teach them how to separate. Otherwise, they grow up having a lot of anxiety issues over that. And I won't even tell you what that result was. And I feel very badly about that. Okay. Anyway, so the infant, the child learns to separate from the mother figure effectively versus non-effectively. And these, Mahler just goes into these different phases. So the rapprochement phase is a critical phase, 16 to 24 months, where if the mother rewards dependence and withholds nurturing when the child expresses independence, there's a lifelong struggle with abandonment that sets in. So here we are looking at, this is a critical phase of learning how to separate. So there's one thing where you can do the run out of the room as quickly as possible and maybe affect your child for life doing that. But you can also nurture too much and reward that kid for being too dependent on you. So almost encouraging that that struggle with separation by not allowing the child to be independent, hovering over the child too much. You know what? Right now, I'm going to say, if you're a parent or you're going to be a parent, it's really a struggle to know what to do. And to do it effectively, because we will read and read and read on what the best practices are for our child, but then we do what we can just to survive day to day with our child. So I'm going to excuse you from all the guilt that you might be feeling right now, because maybe you've done some of these things and you're wondering if that's really messed up your child. Well, know that you can always go and retroactively fix these things. You don't have to believe, like Freud, that it's fixated for life and it won't change. I tend to believe that it can be changed. Thank goodness. All right, so Mahler went through, other phases, and I invite you to go read those to get a better understanding for that. But in terms of relevance to nursing practice, we can understand Mahler's theory of object relations and assist the individuation from the primary or from caregivers. So really fostering independence within patients that might be too reliant, or that they have family members or parents that are too much, over controlling them. We can help them to separate effectively, and that's what Mahler was talking about there. The emotional problems, sense of abandonment versus healthy positive self. So It's like you can do it too much or not do it enough, and you might instill that this individual you're raising becomes, is overwhelmed with a sense of being and feeling abandoned. We try not to do that, but sometimes we just don't know any better. We're just trying to survive day to day. We're trying to do the very best we can. All right, so I'll let you go ahead and read on Mahler a little bit more in your textbook on that, and be as equally horrified as I was. But in the meantime, we're going to move on to Piaget. And Piaget, we know, this is the theorist that works with children and development and really explored cognitive development in children. He believed human intelligence is an extension of biological adaptation or one's ability for psychological adaptation to the environment. How we use cognition to adapt to situations in our life. So he looked at how we actually think about the situation and strategize and plan in the situation to get through. And so, again, you can read about this and understand this, but think about, this is all about thinking. And so he first of all looked at how children think in the different ages and age groups. And that taught us how to deal with kids and how to talk to kids based on their cognitive development. You cannot say abstract things or things that are too difficult to comprehend to a 3 or 4-year-old that you would actually say to a 10-year-old. They have much more cognitive development. So he looked at that. He's where I'm at here. Preschools and early elementary schools rely heavily on Piaget in understanding how kids think. Very, very important. He identified 4 stages of development that are related to the age, as I said, demonstrating at each successive stage a higher level of logical organization than from the previous stage is developed. So we, kind of based on, if you look at Mahler's work there that we just previously discussed, it's, at each stage we become more cognitively aware and we can sort things out. And that's why, babies don't know, or young, little children, toddlers get so wild about separating from their primary caregivers and have such a hard time with it because they can't think through that mommy's coming back. Okay, so Piaget helped us to understand the cognitive development of children. And again, I'm not going to regurgitate your chapter here. I want you to go back and really understand that. So how did we take Piaget and run it into our practices? And so when we think of Piaget, we think of cognitive development. And from cognitive theory is where we get cognitive therapy. Okay, let me try and move that down into the screen a little bit. There we go. So the therapeutic value in nursing practice, we can work with our patients in terms of cognitive restructuring and help the patient let go. So schemas are some of the terms that Piaget talked about. In the child, they develop already a sense of how to survive in a situation. And let's say they're in a school situation and they don't make a lot of friends or integrate into with the kids, the group, they don't assimilate well. They kind of stand on the outside. They go through life standing on the outside and develop a thought about who they are, a sense of self. And this can develop into or enhance, your mood disorders of depression and some of your personality disorders. And the only way one can really help themselves get better is through cognitive restructuring and rethinking these ideas that were set in from childhood. Wow, huh? There's so much that has been done to us that in our early childhood years that we need to really undo. I can speak for myself in some ways that I was brought up that in my adult life, I actually had to go to therapy and talk to a therapist about, okay, so how did I develop this train of thought and how can I undo it? So a lot of cognitive therapy helped me. Now, you can only do cognitive therapy when you're in a mild state of anxiety, no more than that, because as soon as we get more anxious, we can't restructure thoughts because our thoughts are not clear, they're not organized, they're scattered, and that's why cognitive restructuring and cognitive therapy doesn't work with a patient who's in a locked psychiatric unit because they're too anxious, they're too out of sorts, they can't get this down. Now, when they're getting ready to go and be discharged, that's when you can work with that. All right, so wow, there's so much to think about, and I hope I haven't made you too anxious over your own plight in life by talking about all of these things. So look at these things that, in terms of letting go, really relate Piaget to how we help patients with their cognitive development. Focus on learning what these terms of schemas, our automatic thoughts mean, and how we learn to assimilate and accommodate. Those are schemas. Assimilate and accommodate are definitely Piaget terms that you want to be familiar with to help for a better understanding. All right, let's move to the next slide and think about Sullivan and Peplau. And Hildegard Peplau, when you look at chapter 3, it talks about some of the things I talked about in terms of who a good helper is, what makes a really great psychiatric nurse or a nurse that can deal with the mental health of others. We talked about the resource person, the surrogate, and all that. That came from Hildegard Peplau, who was the prominent psychiatric nurse theorist, and actually, really did a lot of good for that and lived a good long life, as you can see, 1909 to 1999. But she went with, in terms of building her nursing theory on interpersonal theorists of Harry Sullivan. And so let's kind of look at what Sullivan and Peplau thought in terms of their theory. And there was the assumption that we are all social beings, and I think as humans we can really relate to that. We are motivated by two goals in life, and that is to satisfy our biological needs. And Sullivan identified that as being meeting satisfaction, and then security, belonging, and accepted within a group. And we strive to reduce anxiety by reaching these goals. So if we can meet our biological or physical needs and also belong and be accepted, we are really going to, make good on terms of developing into very psychologically balanced human beings. And really, when you stop and think about that, look at that. Security, belonging, and accepted, and think about some children and people who are not actually belonging and being accepted within a group, and how that affects them mentally. That's devastating, I think, to think about that. Okay, so here's just a cute little look at our interpersonal theory and where we are interacting and using that. And we're doing that in our therapeutic communication, in group therapy, and the therapeutic milieu. And here is a therapeutic or a group therapy session going on with these Halloween characters and how they're feeling. And it's just kind of a funny little cartoon to look at group therapy and how actually they can help each other out. Okay, so interpersonal theory is another theory that we use in our world of psychiatric nursing. And then we look at the behaviorists. So this is a huge one here. Skinner is the most popular, but you might have heard of Pavlov and Pavlov's dog in terms of behavior therapy. And then there's also Watson. So the assumptions of this theory is that our behavior is learned. We learn our behaviors through conditioning, you might have heard that term, and a sequence of stimulus and responses. So trial and error, we learn through life about trying things out, and when we experience an error, we are taught and we learn maybe not to do that again. So we call those rewards and punishments, positive and negative reinforcements. As I said, trial and error, we learn through making mistakes, through conquest and consequences. All right, so behavior therapy. Behavior theory is widely used in our psychiatric units and in life, wouldn't you agree, when we're trying to help train our animals and also our children. Okay, so therapeutic ways are things, values of the behavior learning. We ways to go about how we modify behaviors through shaping, and we reward each step the individual takes towards changing a behavior. So with a behavior change, we're going to reward and say, hey, you can move to the next step. And we see this in terms of patients. The more privileges they can earn and move to the next step. So they get privileges based on that. Modeling, we will role model for our patients. Other patients role model, this is how we act and behave. And again, other patients see that and go, okay, if I do that, then maybe I will also be rewarded because of that with privileges or what have you. The Premack principle, if you do 30 minutes of physical activity, you can get 30 minutes on the computer. So in exchange, if you do this, you can get that. And again, you can see these work really great in terms of raising children too. And you know, they all want to be on their electronic devices, but you need to earn that by doing maybe some physical activity, you know, whatever that is. I used to do that a lot with my children. And then, of course, we see timeouts. We might contract with the patient. Now, I talked about setting a contract in terms of some therapeutic communication, but we also set contracts in terms of behaviors that patients won't act out on suicidal thoughts or plans, and we ask them to contract for safety. So that falls under the behavior and learning theory. Token economy, in terms of you can earn so many tokens, and again, once you get those tokens, there's a reward for you at the end of that. So we might actually reward with that. You might call that bribery in some cases, but we call that just getting the job done and getting what we need out of that person by rewarding them. So you can see this is just used all over in life. It's applied out there in life. And then another last piece to kind of give an example of a type of behavior learning therapy or theory, looking at this in terms of therapy, is when we're treating phobias with patients. So we might treat patients that are phobic about eating in the social realm. That's social phobia is like eating in public. That's one thing. Let's talk about a more simple phobia, and we'll go through this when we go through anxiety disorders. But maybe you're afraid of a certain animal type. Maybe it's a snake or a mouse, or I'm not really fond of spiders. If one were to jump on me right now, I'd probably throw the computer across the room, and that wouldn't be good. But when these phobias or these fears get in your way because you can't function in life with that, you might have to systematically desensitize to that. If you needed to travel for your job, but you won't get on an airplane, but this was the best job in the world to have and you had to have it, you might want to go through the systematic desensitization and systematically over time get more and more used to it and accustomed to where you're no longer afraid of it. Or you might just try flooding and implosion, get on the gosh darn plane and get there and just live with it. Okay, so there's ways of treating fears and phobias by either desensitizing over time or just get right in there and get it done. Let that spider sit on your hand and crawl all over the place. Not today. I don't think so. All right, so another big theory is psychobiology. Again, just touching on this and looking at this. So we go into the next chapter of your book and looking at that. And you can look up the chapter. I'm not sure if it's chapter 4 or what, but it's really adjacent and within line of the chapter 3 that we just kind of just got through. Chapter 2, chapter 3, and here we go, psychobiology. So it's important to understand that we didn't really start thinking of this theory until the 1990s, which was identified as the era of the brain. And I'm telling you, I started teaching in 1994 this course, and it was just coming to be an aha moment in the world of psychiatry that maybe some of this issue of psychiatric illnesses actually had to do not with the mother, not with society, not with the way we learned and developed our cognitive brain, but actually in because of psychobiology, that it might be the brain. And I said, well, what took you so long to think about that and accept that it might be the brain? And do you know that in 1994, it still wasn't widely accepted, that some of the practitioners just would not let up on that mother? I am telling you that, really. And so here we are, now there's a greater understanding. Thank you to technology and being able to look inside the brain and how it's actually acting and behaving. And we see that with the PET scans. SPECT scans too, but PET scans are a lot cheaper than SPECT scans, still very expensive, but have been able to allow researchers to look in the brain without waiting for somebody to be dead on autopsy. That is just not too long ago when you think about it. Wow. So very new frontier. So we know different 6 sections of the brain, and I ask you to just kind of get a basic understanding from brain anatomy. Just review your anatomy, physiology, and know what these basic structures do and how they function. You don't have to go into much. Very, very basic. I'm telling you, we will cover a lot of this in more detail in Nursing 242. So just understand where some of maybe the relation to a problem that somebody's having emotionally, psychiatrically, is related to what part of the brain. Okay, that's it. Very, very basic. I'm telling you, don't go crazy over this. All right, so nervous system and the tissue. So again, just understanding how nerves relay information and how they shoot down through the axons right out to the dendrites of the next nerve cell, okay, next neuron, transmitting. What are they throwing down that little pathway? They're transmitting basically neurotransmitters. And that's important to understand because that's how the medications work. That's how they think they work, they being the researchers, that there's actually a change in the neurotransmitters. So I just flipped right into the next slide here. Speaking of neurotransmitters, and what are the major categories of neurotransmitters? Well, there's cholinergics, monoamines, amino acids, and neuropeptides. Let's just look at those and look at the basic neurotransmitters that are italicized there, okay? Those are the ones you want to kind of get a good understanding for and how they function, because the medications in terms of mechanisms of actions, when you read up on those medications, it's going to say it is thought that these alter these certain neurotransmitters. So we will get a foundational understanding for them. Coming up right now, we're going to look at that. And then again, I always say go back to your book, go to ATI, review this to get an understanding for it, okay? I'm going to touch on it, and I don't regurgitate too much out of the book because there is some reading to do. Okay, so neurotransmission. We have a resting nerve cell here. Nothing's coming out of it. No neurotransmitters are going anywhere. And you can see here are the neurotransmitters, but once that cell is firing and is activated, neurotransmitters move. Okay, so they're moving into the presynaptic cell down to the postsynaptic cell. And then right in between here, this is where some of the medications either will inhibit that neurotransmission if they're trying to prevent a certain neurotransmitter from, maybe we have too much of that. So let's just take, for instance, dopamine. Maybe we're trying to keep dopamine right where it is, or we're not allowing it to be reuptake into the postsynaptic cell here. We don't want, we're going to inhibit dopamine transmission. And that is what antipsychotics are allegedly doing. Well, they kind of know this, the researchers, because they can see the metabolites and what have you. It would be really nice if we can actually see into the brain active neurotransmission and identify those neurotransmitters to say, yes, this is absolutely what's happening. So when you read about your drugs and mechanisms of action, it's going to say it's thought to be. All right, so pay attention to this and look at where our dopamine is being transmitted, or our serotonin, or our norepinephrine. It's all going to, we either want more of it or less of it, okay, of the neurotransmitters. All right, so next slide, let's look at what we have the most of, which is actually a good thing, don't you think? We need excitable neurotransmitters, otherwise we're going to be just blobs on a piece of paper and we're not moving anywhere. So neurotransmitters not only help us with our mood, but they also help us physically. Okay, so looking at acetylcholine, that was one of the neurotransmitters on 2 slides ago to look at that. Sorry, didn't mean to do that. Let me get out of there. We go. Okay, so we're just looking at this screen here. Excitable neurotransmitters. Acetylcholine helps with our memory, learning, our mood, or sexual or aggressive behavior. So if we have too much learning, we might want to tone down the acetylcholine. No, I don't think so. I think we might want to tune that up a little bit. Don't you think that's good? But what about aggressive behavior? We might look for a drug that helps to work with toning that aggressive behavior down. So developing a drug that inhibits acetylcholine might be helpful. But look what happens. It also affects your memory, your mood, your sexual behavior as well, and maybe learning might be affected. So it's really hard to develop a drug that's going to address just aggressive behavior without having side effects here. Okay, moving on to dopamine. And by the way, all your drugs do that. They're there to help one thing, but they're going to affect other things because they don't just hang out in the brain, they go other places. All right, so dopamine, fine motor movement, sensory integration, emotional behavior. It is thought that people that have hallucinations and are psychotic need to have their dopamine controlled. But what happens as a side effect? So is their fine motor movement. Maybe other sensory integration, okay, is affected. Now, they might have too much sensory integration. That's why they're hearing voices or seeing things that are not there. So that's good, but it might also make them a little bit more depressed. Okay, so we took care of the psychosis and the hallucinations, but we have some other side effects as well. This is why patients also don't want to take their drugs, because of these profound side effects. And then we have norepinephrine. Norepinephrine, if we have a lot of that on board, we have a lot of fight or flight happening here, which is a lot of anxiety. Isn't that stressful to have that? So we might want to tone that down if there's too much of it. But if we tone that down, we're also going to get very, very depressed. So we need to bring that up a little bit. All right, serotonin. Serotonin is for our alertness, transmission of sensory pain. Not here also, but helps us with our mood. People that are depressed don't have enough norepinephrine or serotonin. So we need to give them a little boost and have a little bit more of that hanging around. But again, it might affect. Maybe it's going to keep you up all night and you're going to have sleep problems or other things. So it's not an exact science. Pharmacology is not exact. It helps to help with one problem, but it can give you side effects and cause harm in other areas. This is why it's so difficult to deal with, especially with mental health issues. And then histamine. We've heard of histamine. Now, I don't like a lot of histamine because histamine means that I'm going to scratch and itch. And that's what those little stupid mosquitoes do to me when I'm out there and about in the world getting bit by mosquitoes. But histamine internally is good for us because it helps us stay alert. Okay? But, and so if we need to, we may need a little bit more of that, stimulate that. But histamine also causes the inflammatory response. Hence, that's why we itch so much after being bit by a mosquito. And it also, when we ingest things that have too much histamine, we have a lot of gastric secretions, and that results in maybe some reflux or gastric pain. All right, you're damned if you do, damned if you don't on some of these things. Okie dokie, moving to the next slide. Well, let's look at the most important inhibitory neurotransmitter to know, GABA. Okay, this is what it's called, gamma amino butyric or traic acid, but we'll just call it GABA. So when this is an inhibitory, okay? So GABA is needed to inhibit excitability. It makes us more inhibited. It slows us down. Okay? So don't forget this. It slows down. All right? It slows us down. And the more the one has of this, the slower they will be. So we just hear about all these excitable neurotransmitters, and the more you have it, the more excitable you're going to get, or the better mood you're going to have, or you're going to be more psychotic. When we have more GABA on board, we're going to slow somebody down. And so your anxiolytics, your benzodiazepines are thought to, we're pretty sure, promote GABA. They throw a lot of GABA out there, thus slowing somebody down or calming them down. Wow, sort those out, huh? In terms of what we know. This is all going to be relative when we look at some therapies and what have you. Okay, some last words about what kind of problems or where the theory is and the therapies related to it. So when we're looking at psychobiology and we're looking at neurotransmission, it affects the parts of the brain. It makes us change our behaviors, but it also has some side effects that help us or feel differently physically, and that can be an issue and a problem. All right, what other ways in terms of psychobiology causes us to behave differently or have emotional or psychiatric disturbances? Traumatic brain injury. It changes us in our cognition and our mood. And also it has physiological changes, but thinking of that psychologically, cognitive and mood changes. Abnormal brain development in our structures, developmental delays, those also equate to sometimes behavioral problems. Brain lesions, a tumor or a abnormal growth of some sort, or a lesion maybe in the form of an aneurysm will compress brain tissue, altering brain function, and depending on where it is when we look at the basic structure of the brain, will result in problems with motor, sensory, memory, or thought pattern disturbances. So again, go back to the picture of the brain, look at that and say, all right, where will I have psychological issues based on problems in these brain structures. And again, a lot of this is theory based on research and looking at individuals. A lot of it is not nailed down in terms of absolutes, because that means we have to look at a brain as it's actively working, and that's difficult to do on a live person. Would you sign up for that? To have your full-on craniotomy just so researchers could look inside your brain? I don't think so. Unfortunately, our lab animals get to do that, and then we have to make assumptions based on them. All right. Genetics. What do we know about that? A lot now. Okay. So the Genome Project has actually identified where genes lie, and then they've identified mutations. So it's rapid science coming out with understanding where genetics influence us. And we see that because patients have families that have the same type of problems. We make the assumption it's genetics. We can also make the assumption that it's a gene mutation. Some have been identified, some have not. So behavioral genetics clarify the role that genetics play, definitely. So a good, big opening area of science. Genotype is the total set of genes in an individual, and they can be identified now. Phenotypes are the characteristics that are not only genetic, but also may be acquired. Okay, so that's just the way we look. And then studies do determine causes or etiological factors. When we study families with the same type of psychiatric illnesses, we look at the similarities in twins, and then we compare that to maybe twins that were separated at birth and were adopted, but yet come down with the same psychiatric illnesses, suggesting that it's not influenced by the environment, upbringing, or what they learned in their society, but really a genetic thing. Okay, we're nearing the end here, and we're looking at hormones, and what do hormones, how do they play? And I love this little cartoon here. Women can certainly relate to that. And here's a fact: women are more likely to kill during the 2 weeks before their period. Would you agree? More research is needed here. Research tends to not really take this seriously, and but with more female researchers, maybe we'll get that taken more seriously to look at that. Disorders of the pituitary gland will change our mood, influence our personality, etc. And then the last slide here we go, is looking at other influences, the circadian rhythms of our sleep-wake cycle. That definitely influences our psychobiology. If you don't have a lot of sleep, you're not in the best mood. Agree? And psychoimmunology stresses, looking at the compromises immunity may have, environmental immunity might be linked to grief, alcoholism, and schizophrenia, perhaps. We don't know. Lots of studies out there looking at our immune system and how we react to our environment that way. And with that, I end this lecture. Whew. Now, let me make sure that I actually can hear myself. Take care and goodbye.